So today we're going to talk about polymyalgia rheumatica, so PMR, going over what is the current evidence and what does it mean to us in primary care to assess and manage. So we're not going to go over really much of secondary care management, but what do we do in primary care and when do we need to look at secondary care? So as always, please, if you want to raise your hand, put in the chat, speak up, please. This is meant to be an interactive session. We are very lucky today that we've got a range of clinicians. So myself, Desi Gillespie, I'm a physio background. We've got Sim, who's a physician associate, and we've got Paul, who is a paramedic ACP. So what we're going to be doing today is bringing our different perspectives, and that's where please bring in your perspective as well on managing PMR. I will hand over to Sim.
Hiya, thanks Desi for that. So as we start, we're going to go over the objectives to start with today. We're going to begin by presenting current literature on the assessment of PMR. We're going to look at the features of the inflammatory presentations. We're going to go over some of the differentials, investigate what is the appropriate investigations for this condition, and consider when is it appropriate to refer to rheumatology. And then we're also going to look at some of the pharmacological management in primary care and have a look at the steroid card considerations. So what is PMR? PMR is essentially a chronic condition. It's an inflammatory disease that essentially starts with pain, usually morning stiffness, and is commonly in the neck, the shoulder, and the sort of pelvic girdle area. It usually or primarily affects the older adults and usually those who are around or over 50. And these symptoms often are worse in the morning and last for a couple of hours. So this is an immune response where the body's immune system attacks its own tissue by accident. It doesn't mean to, it sort of just happens, it's just a response. And there are some common and less common features of this. So you should suspect PMR in a person, like we say, that's over 50, that's presenting with at least 2 weeks of the following symptoms. So bilateral shoulder or pelvic girdle pain, bilateral obviously meaning both sides. Initially, it might be one-sided, but very quickly it may become both-sided and it worsens on movement. People who suffer with this may not always be able to sleep and have interrupted or sort of delayed sleep. And shoulder pain may radiate to the elbows and is usually one of the most common features. And the lesser common feature would be the hip or the neck pain, which is in around 50 to 70% of people. And this hip pain can actually radiate to the knee. If you just go on the next slide, Desi, sorry. Yeah. Stiffness lasts for about 45 minutes after waking up. Not always, but usually about 45 minutes. And you may kind of feel it when you're turning over in bed and you have difficulty with that, or you're getting up, or you're moving out of the chair, or you're putting your arms above your head. That's when you're going to feel it the most. Now, less common features. Next slide. That's it. Less common features may be things such as having a fever. However, a fever is quite broad spectrum. That could mean a number of things, but you might have a low-grade fever. You may feel really, really fatigued. Again, fatigue could be a number of things. You could be anemic, but again, is a lesser common one of this condition. A lot of people might be anorexic or slightly underweight or losing weight, and also depression can also play a part in this as well. You might have bilateral upper arm tenderness, not always, but sometimes, and some MSK signs that are in around 50% of people might be those such as carpal tunnel, which is a condition that we discussed last week, peripheral arthritis, and swelling with pitting edema of the hands, the wrists, the feet, and the ankles. So pitting edema is when you put your hand on your skin and press, and it leaves a little pit, a little well. So muscle strength isn't always or usually impaired, but you may have muscle pain, inhibition, making it difficult to test. If symptoms are protracted, there's disuse, atrophy of muscles that can occur, and basically it can lead to muscle weakness. Over to you, Desi.
primary myself. Your more common population is going to be your over 65. So we say over 50, but anyone over 65 have that suspicion higher up in your differentials. It's more likely in women than in men, and more prevalent in the Northern European ethnicities. So, differentials. So I already warned you, there is a bit of interaction. So if someone's coming in with multi-joint pain and stiffness, in the chat, unmute yourself. Give me some other reasons why we might get that. It's not always going to be PMR. What else? What other bells should be ringing? I even gave you a warning today. Yep, Emma, I can hear you talking.
Sorry. Anything like fibromyalgia or any cervical issues or hip arthritis. So there's many different ones.
Brilliant. Is it Ihor?
Yeah, when it was mentioned, it starts off with unilateral weakness progressing to bilateral, but initially in the initial stages, if it's unilateral, it could be potentially part of like CVA symptoms, but I'd obviously have to carry out a fast test with that, but it could be part of that, or, you know, one of those symptoms.
Very good. So in the chat, we've got more polyarthritis, so osteoarthritis, chronic fatigue, as well as fibro, undifferentiated inflammatory. So yes, it's always, and then we've also looked at Michael saying about vascular. So it's making sure that just because they're X age, it must be PMR. Always have that suspicion of what else it could be, and it's what are you ruling in and ruling out. But I'm teaching you all to suck eggs. So we've got here, so rheumatoid, so we've already talked about that. We've not ruled out a little bit of the red flag, so what else could we be considering? So yes, depending where the pain is. Are they unwell? Any thyroid pathologies, myeloma, and fibromyalgia? That's the most common one people will think of with widespread pain. So from the feedback, people have asked for a case study. So today we have Mr. Jones. He's walked into your clinic, whatever profession that you are. He's 72 years old, and he hasn't been to the GP in the last year because he's not a frequent flyer. He says, both my shoulders are aching for the last 6 months. There was no real reason that it's come on. I've not done anything, and it's really tight around my neck area as well. And in the morning, I'm struggling to get dressed and reach up for my coffee cup. What do you want to know? That's all he told you, and it's now on to you.
We should have perhaps added in that he's a 72-year-old Viking, because that then feeds with the ethnicity data, doesn't it? That would add to it.
We could. How did you arrive today? Was it on your ship? Is there any joint swelling or early morning stiffness?
Yeah.
Can you expand on that, Edie?
Yes, generally, if we're suspecting something inflammatory, multiple joint pain, we usually check for pitting edema again, which was mentioned earlier, which is a classical sign that we see with polymyalgia. They generally present with pain, swelling around the metacarpal metatarsal region, and generally stiffness is accompanied with which is classically more so in the morning, lasting for more than 20-30 minutes is when we're suspecting something inflammatory.
Good. And then medication check. So actually, Mr. Jones, he doesn't show up. He's not on any medications. He's doing well. Pins and needles or neuro. So Emma or Neelam, can you explain to me, what are you going to ask?
Does he have any tingling, pins and needles in his hand? Does it wake him up in the morning with pins and needles? Any dizziness, drowsiness, blurred vision, 5Ds and 3Ns? Any past medical history of neck? Any scans done? Any other significant past medical history?
Good. And he's got none of that. No. He really doesn't like going to the GP. He's a really fighting fit Viking. And then loss of power. Just clarify on that.
So any does he drop things from his hand? Has he lost any strength? Yeah.
Yep, so clumsy, yep, dropping things. We've talked about long-term statin use. That can cause shoulder girdle weakness, but no, he's not on any medication. We're not worried about that. Weight loss. No, he's a sturdy Viking. Eats his calories and his proteins, he's good. Hip pain. yeah, actually, he notices that his hip pain, he just can't quite stride out as much as he used to.
And that's it. It's interesting to kind of eke that out, because yes, he's come because his shoulders are tight and his neck's tight. But yeah, exactly, Emma. Kind of checking to see if he has any other joint pains that could be added to us.
I don't want to put you on the spot. I'm hoping you're going to say, oh, we're ruling out GCA. So it's exactly what
Beautiful.
we want, is that if we're saying kind of that neck tightness, it's just ruling out. So again, we've given the age, we've told you he's a Viking and he's not really a frequent flyer with no other neural concerns, that it's just, as Paul said, sometimes they won't bring up that actually, yes, my vision's getting blurred, but I thought because I'm old, that's why it's coming on. So it's make sure you draw out that it's not that GCA, because that is when it becomes a medical emergency, and that's what we're not going to talk to on that today. But yes, so rule out these kind of questions. Now, I might appeal to more of the physios in the room now. So if someone's got bilateral shoulder pain, what else do you want to know? It's not exclusive to physios, but bilateral shoulder pain. What else? So he's got range of movement. It's actually 5 o'clock, so his range is pretty good right now. But if you asked him for a 9 a.m. appointment, it wouldn't have been as good. So he can get it. He's had no injuries. So no, he's never had surgery, no injuries. He's a really fit, healthy person.
What can we ask him about how he deems himself to be fit and active? Because everyone says, "Oh yes, I'm really active."
What have I told you? He's a pickleball champion. He plays pickleball 4 times a week, and he's just had the championship tournament recently, and his training's been upped. So drawing out, looking at occupation, what are their hobbies? So when we look at shoulder pathologies, we're going to go a little bit into classic signs of PMR, but just make sure you look at this patient as a whole. So we look at bilateral shoulder pain, but is it that they've just become a weightlifter, or they've just started a new sport, they're doing more overhead pressing by type movements, that sometimes there is that mechanical element. So we've talked about all the nasty things in terms of, is it neuro, is it X, is it Y, but actually have a look at what is their function, what do they do, has anything else changed? So over the 6 months, he's now really fit and healthy because he's more active, but is that a reason why we might be getting more almost tendinopathy type symptoms? And it's both arms, because he's using both arms. So it's just think that lateral aspect. So going into assessment, that subjective history. So what has actually happened? How did it come on? Was there a mechanism? Is there any other comorbidities? So exactly what we said about medication, that we've ruled out other pathologies as well. Rule out the red flags. That's always the key thing in primary care. What about the functional factors? So actually drawing out, so he's struggling with his coffee cup in the morning to reach it because it's on the top shelf. Is there anything else day to day struggling with? So dressing, can you dress yourself? Can you wash yourself? Can you get out of bed? So is there any other, do we have to get anyone else involved? Can you turn over in bed? So can you get out of a chair? Drawing out those questions, and sometimes you've got to ask those questions to prompt that actually, yes, I am struggling with that, or I thought it was normal that people struggle to get out of a chair. So there is a classification, so the EULAR criteria, and again, it's not a true yes, no, it supports your diagnosis to almost rule in, rule out, or question yourself further. Objectively reviewing the patient, so people have already put looking at red hot swollen joints. Would we expect that probably in this patient? That's just more shoulder, not so much on this Mr. Jones, but again, having a look, is there more of an inflammatory picture to this patient? Is it that they have got that kind of peripheral osteoarthritis and they've got nodules, which again is one of our kind of risk factors? Consider the time of day this patient's come in. So I said earlier, it's 5 o'clock. We've got great range of movement, but if it's a 9 a.m. appointment, is that a bit different? So do factor in when the patient is seeing you, asking, what would it have been like if I saw you first thing this morning? And also, like part of the assessment, and we'll talk about it a little bit more, is when you consider bloods. So to help draw that whole picture for you. So in terms of decision-making tools, so you've got the EULAR, so that's now in the chat. it's more of a point system, so a bit like your DBT, your Wells score. What can you do in primary care? So it normally says that if it's something less than 3 months, bilateral shoulder pain with no kind of mechanism of injury, looking at a score of 4 or higher, or if you do, that's without doing an ultrasound, or 5 or greater if there is an ultrasound. Now, how often are we going to ultrasound? Because what is it going to change? So that's what I'd always question. What we don't want to do is send people off, because what is that going to do for you versus doing some bloods? And that's where I said bring out the whole picture. So is there going to be a tendinopathy because they do a lot of overhead movements, because it's now summer season and gardening, hedge trimming has been going on, and actually that might be the reason there could be a tendinopathy bursitis type change. Now poll time. So I'll put a poll in the chat. So it's going to be multiple choice in one moment. And let's just write in the chat. What are the things? What do you want to know in your bloods?
Is there anything that you would add to that list? Are you going to do quite a targeted set of bloods in order to rule in or out PMR, or are you going to look at other factors, trying to differentiate as well? Are you just going to be looking for PMR, or actually are you going to look to rule out other pathologies? So yes, CRP and ESR, yeah, inflammatory markers, yeah, perfect, Milan. Inflammatory markers, yeah, adding in LFTs as well into unis, let's see, yeah. CRP, good. Anyone would miss out any of the bloods on screen? So ANA or HLA.
CCP I would add in. And
I spotted a urate for gout as well. Yeah, always tricky in terms of the timing of urate, because if they're symptomatic, it could be falsely reassuringly low. But yeah, it's certainly worth a shout. It's something that you would want to keep an eye on, and potentially, like you say, add as that differential. Sarah, CK, yeah, definitely. Is this soft tissue driven? Obviously, like we've said previously, with the shoulder girdle pain and statin use, yeah, definitely. And that would be even more so the case if we've got statins in play as well. So yes, looking at all those inflammatory markers, yeah, FBC, CRP, ESR, thyroid as well. Yes, always. So doing that, would you actually be looking more to rule in rheumatoid rather than?
I mean, if you're doing ANA, which is less sensitive, it would be rather worth adding CCP, which is more sensitive, to rule out rheumatoid.
Like I say, with ANA, and then potentially putting in rheumatoid factor as well,
yeah.
Because then you're going to be supported one way or the other. If we're wrong and comes back positive ANA, positive rheumatoid factor, even though we're thinking, oh, it's probably PMR, actually that comes as a nice kind of diagnostic failure, in that we've gone one way, but actually because we've been a bit more open and using the bloods to look at differentials as well. So yeah, totally, yeah, using CCP instead.
Yeah, sorry, but rheumatoid factor is even if it's negative, but if CCP is positive, it's more sensitive, specifically for inflammatory arthritis.
Yeah.
So in orange, this is what the Nottinghamshire Rheumatology Guidelines request. Just going to put that out. That's what they ask for in our region.
Yeah, CCP. That's what. Yeah, CCP is more specific.
Yeah, and that's why it's in there as part of the guidance. So yes, if you're going to just do the a generic blood panel looking for inflammation, if you're just going to do FBC, CRP or ESR, then yes, there's going to be lots of things you miss. So yes, certainly adding in CCP and rheumatoid factor is going to be useful. And it's very much about balancing those results, because there isn't just a single a single blood test sensitive for PMR. You're going to expect to see a mix of results. You're going to expect to see an inflammatory response, but even if those come back as within normal limits, a diagnosis can still be made. But like we've touched on, as you touched on, certainly with positive CCP and positive rheumatoid factor, you're going to be looking at alternative pathology. Is it that they are presenting in an atypical matter, or is it just that there's part of the story that's missing, or is it just that their symptoms are, like Desi touched on before, are they downplaying some of their symptoms? Or was it Emma in the chat mentioned the hip pain? So actually, yes, is this a polyarthritis, a systemic rheumatoid arthritis, but the only reason they came in was because it's now got to that point with their shoulders. And again, looking for differentials if you're going down the myeloma route instead. You can consider other tests for Bence-Jones protein, but that's probably not something you're going to be doing on every single patient that walks through the door with shoulder pain. So in terms of bloods, yeah, that's what you're going to want, and that will give you a good picture of what's going on. Is there any other investigations that anyone would do? So would anyone then want to move onto imaging, or would you just happy to go, yep, I've got some bloods, they've confirmed, let's go ahead? Do you think there's any value in imaging, or do you think it's a requirement? What's anyone's thoughts? Any hands or comments in the chat?
I would just explore, not necessarily, but just explore vitamin D and B12.
Yeah, really good idea. Really good idea, especially if you've got, because like I say, they've got joint pain. So yeah, always worth vitamin D and B12 as well. Some studies show recommendation for chest X-ray. Yeah, if I know, ultrasound probably as well. Yeah. Any more responses in the poll?
I think it would depend on what your subjective findings were as well. Because if it's presenting more of a tendinopathy in the shoulders, yes, I'd potentially look at ultrasound for the shoulders. Or if you examined your hips and you thought there was some arthritis in the hips, yeah, maybe a pelvic X-ray. So it depends, I think, entirely on what the blood results would be and on your subjective assessment.
Yeah. Do you think that would be led partly by severity as well?
Yeah, absolutely.
Yeah. So if they come there, oh yeah, I just noticed the last few months I'm a bit, my shoulders are a bit sore. Whereas actually, if they come in and say, yeah, the last 6 months have been awful. I can't reach for my coffee in the morning. My shoulders, I just can't use them for the first hour of the day. I can't reach I can't eat and drink. I can't dress myself until 9, 10 o'clock in the morning because I'm just useless. And like you say, if their symptoms are more isolated, then yes, looking at USS of shoulders.
I'm going to challenge that. Why? So if we're considering a tendinopathy, what's the ultrasound going to change? Just out of clinical discussion.
I suppose it would just rule in or rule out a tendinopathy, and then it would guide your treatment down a certain path, whether you're looking at corticosteroids or physio referrals. But it depends what I found on the subjective, on my special tests, really.
And what I'm hinting at there is more, it's what is a ultrasound going to do? So I know we see quite a lot of people getting referred when we know it's a tendinopathy or a subacromial pain. So it's exactly what you said. If it's the whole picture, if it would change the management, but it's just be mindful with ultrasounds that I know it's in that EULAR, but again, having a look at what else have they been doing. So is it hedge trimming season? And actually, we've got a high suspect that it could be. And depending what region you're working in, like if you're going to do a steroid injection, you don't need an image. Obviously, some places say you have to, but it's not as in the guidelines that you need to do imaging beforehand. So it was just food for thought. Sorry, Paul.
No, perfect. That's what the whole discussion is about. So yeah, investigations. There's no set requirement for further diagnostic imaging. Yeah, ultrasound. Yeah, it's going to show potentially other inflammatory causes, bursitis, tendinopathy. Yeah, fantastic. But again, as Desi's touched on, it's going to be essentially exertion related or activity related. You're not going to make a diagnosis of PMR purely because you've sent someone for a shoulder ultrasound because they've got isolated symptoms. Is it a bilateral injury or is it actually a systemic issue? And again, similar with X-rays. At this point, is it going to change anything? Is it going to shape your treatment at all? Or are you still going to be treating exactly the same way, whether an X-ray comes back as showing kind of polyarthritic changes, lots of bone-on-bone articulation and osteophytes, or actually are you going to look and say, oh yes, there's a lot going on here. It's across multiple joints. Actually, yes, it does look like something systemic is going on, and therefore more likely to start treatment for PMR, or are you going to be looking at further referral to rheumatology, which is again something we'll touch on in a moment. Is it within your remit in primary care to do something about it right now, or are you going to pass them on to someone else?
So Mr. Jones, his bloods have come back as raised, so we are suspecting PMR. So we've got the wonderful Sarah, if you're still here, about initial management.
So brilliant. So often I would only become involved after the initial management has happened and stabilised. But according to NICE CKS, if PMR is the most likely diagnosed, they'd offer oral prednisolone. And the normal starting dose is about 15 milligrams daily. And it's important to check that that's made a difference to symptoms. So normally it's recommended that a follow-up happens after 1 week to check if it's clinically worked. You'd also do a follow-up 1 week after any change in dose. So you've started this prednisolone. The considerations and counselling points that we kind of want to give the patient is that they take the prednisolone in the morning, so that we're kind of mimicking the kind of natural corticosteroid response and things like that. Other things that we might want to consider is stomach protection, but we'd only be offering that if they're at high risk. We want to be making sure when we're starting anyone on prednisolone that we counsel them on mood changes and sleep changes and the other side effects. So thinking about stomach irritation, and things like that, muscle weakness, easy bruising and weight gain. When we're reviewing them at 1 week as well, we would also be wanting to check on the symptoms of giant cell arthritis, which have already been touched on. So sudden changes in kind of abrupt headaches and things like that. And we'd also be wanting to check that they've not got any of the PMR symptoms. So we want to check that the PMR symptoms have gone. So like the pain, the morning stiffness and tiredness and things like that. Paul, have you been involved in starting any prednisolone in PMR? And is there anything else that you would add there?
Yes, it's I have, and yeah, you've hit the nail on the head. Yeah, generally 15 milligrams daily. I think one of you've touched on the importance of reviewing the patient and counselling them about possible side effects. One thing that I think also is really important to counsel is duration of treatment. Some people come in and think, yeah, I've got these, my shoulders have been awful. Yeah, we're going to start you on a course of steroids, and brilliant, I'll be fixed next week. And no, not the case. Essentially, you're going to be looking at kind of 18 to 24 months as an average. of steroid course. So yeah, the only thing I would add to that is certainly counselling around duration of treatment. As Sim touched on in the introduction, you know, this is a chronic problem. This isn't something that really comes up and then disappears quickly.
And this is where signposting to patient resources and things is really, really important for that ongoing support and reassurance, I suppose, of management of realistic expectations. So yeah, signposting and making sure the resources are given to them is really critical. So
can we just touch on considering bone protection?
Yes, is it on my next slide? So it might be on the first slide, but yeah, bone protection would also be important if anyone's on. So they might be on steroids for 1 to 2 years. So we need to consider bone health. You might need to assess their bone protection, use the FRAX calculator, or refer to someone that can review the bone protection and make sure they're having adequate levels of calcium and vitamin D. So yeah, think bones, think stomach, or with the prednisolone. So this is where often a doctor or GP will hand over the management of a patient to a pharmacist. This is where I would often get involved. So they're stable on their prednisolone 15 milligrams, and we need to start weaning them down and based on their symptoms. Now, the example reduction is just an example. It's all about shared decision making, and you may need to give doses for longer or stay at the lower doses for things like that. So it's having those discussions. But one example is you give 15 milligrams for 3 to 4 weeks, then reduce to 12.5, then 10, and then 1 milligram reductions until stop. So that is literally like doing it very, very slowly, reviewing the symptoms, so that muscle, morning stiffness, that tiredness, that pain, and that review going, oh, actually, I think I'm okay. Can I stay for another 2 weeks on that 1 milligram, and then reviewing thereafter? So that is an example, but yeah, it's working with the patient and going slowly with their agreement and reviewing regularly, which is why the pharmacist is quite good at doing that, because they can arrange the scripts and things. So other considerations that need making is if they're on steroids for more than 3 weeks, they'll need a steroid card. I've got that in the next slide. They also need blood monitoring. So we want to check their full blood count, their ESR, CRP, urea, and electrolytes. And then because of being on steroids that can affect blood pressure and sugar levels, we need to be looking at their blood pressure and glucose. And yeah, we said about the osteoporotic fracture risk. And if you want any more information there, then the NOTS APC have some really, really good guidance there. So they used to call the steroid code, I think it's still in CCAS list as blue, but it's not really blue anymore. But it's really important that we encourage our patients to give that, because it's got advice on what to do. Because your body gets used to having the steroid, it needs to not be stopped abruptly. And actually, if they have an infection or they become unwell, they might need extra doses of steroid to cope with it. And we should also be making sure that they're aware that if they come into contact with anyone with chickenpox, shingles, or measles, that they seek medical advice, because they might need some kind of antibodies or treatment based on that. So making sure they're carrying that card and aware to seek medical attention. Anything else, Paul, that you would add?
No, like I say, it's really important to make sure they're aware, and like I say, see it as an ongoing treatment. And like I say, you may have to up titrate doses if they've been unwell, or there might not even be a trigger. Some patients just don't tolerate a steroid drop, so you then just have to take a step back and continue until they're really slowly bringing it down. And you get some patients who are very impatient. Oh, I've been absolutely fine with 5 milligrams, so can I just come off them now? No, not unless you're going to end up going back up to 10, because you're going to flare and you're going to be worse than you were. So yeah, just and really important to touch on, like I say, exposure to things like chickenpox, and because there's going to be a low threshold for either immunity checking or antivirals for things like that.
It's slow and long is generally the rule, and it's important as well to have those red flags of when you might refer to the specialist. So if they've been on treatment for over 2 years, or if you're really struggling to reduce them down, those might all be reasons why you might refer them back. Flags of when you might refer to the specialist.
Yeah, if they're not settling, if you're not managing to titrate down, or you keep having to titrate back up, or if symptoms are developing whilst they're on steroids, if something's changing, essentially if they are atypical, then that's when you want to get rheumatology involved. It might be a simple advice and guidance. You can just then lay it all out in a single task, saying, look, this is the regime they've had. Is there something I'm missing, or do you want to see them? Do you want to do any more investigation or further management? But as far as primary care is concerned, if we've done the diagnosis, we've considered imaging, we've got some detailed bloods back, we've started them on a sliding scale of steroids, we're weaning them down really carefully, either through GP, ACP, considered imaging. We've got some pharmacists, we've got a multidisciplined team who've had input on them. But if it's just not going the way you want to go, you're going to have to ask a grown-up, and you're going to have to refer through to rheumatology and get their advice on this, or perhaps even have them take on responsibility for the patient. But yeah, we've done a good job in primary care of getting them as far as we can. But those some atypical cases just need advice on this, or perhaps even so. A really useful patient information leaflet via room info. It's always good to give the patient a bit more background information, because they will be, with a better understanding, they're going to be happier taking the steroids for longer if they know why. And really just giving them the background to what's going on, and when to come knocking back at the door. So yeah, if Mr. Jones has been settling, but things just aren't going the right way, if he knows when to come back, then fantastic. And as we've touched on, this is something that lasts a fairly long time. 18 to 24 months of treatment. But generally, actually, prognosis is good. Yes, occasionally people can relapse further down the line. But yes, this isn't something that is going to finish people off. But it's uncomfortable for them. But kind of bearing in mind that it can be controlled. So yeah, 43% relapses within 1 year. But actually, again, that can be again, we're looking at a tapered response.
I was just going to say, I think on here, like, the evidence says about that you should be reviewing them like 1 to 4 weeks before remission, and then every 1 to 4 months after the first year. But what's realistic in our current environment? So I think that's what making it real. So that's where that education to patients of this is when you need to come back to me. So if we can't offer that, and I appreciate in some environments you can, but if you can't offer it, saying to the patient, even after a year, if this happens, just book back in. Yeah, and then probably looking more at the musculoskeletal side. So it's making sure that, yes, we've got the PMR, but are there actually osteoarthritis? Are there things like your carpal tunnel that actually it's making sure they're under the right people? That, yes, PMR itself is going to be more of that medical management, but what are we looking at in the prognosis side of getting them active again, having a look at pacing? Exactly what Paul said, so use your MDT. So yes, we've got it from the medical side, but also how can we get people active doing their day-to-day? We went back to the beginning of, can they turn over in their bed? They're struggling to get off a chair. Do we need to get community reablement services to put in adaptive equipment to support that independence? So again, in that prognosis, back to the chronicity, looking at that whole picture, not just that medical side. Anything else from anyone? Otherwise, in summary, So again, it goes back to kind of what do we do in primary care? So making sure we're doing that full assessment and considering our differentials. What else could it be? Using the blood test to support that decision making, and starting that oral prednisolone. So if it's a typical, that's where it'd be more of a primary care management. The Nottinghamshire guidelines is only atypical, or obviously, like Paul said, if things aren't getting better with that initial management. Encourage that person to be active, but with modifications. So use your kind of first contact FCP. It might be a health and wellbeing coach if it's more to support with the activity related, obviously not just the medical diagnostic side. Having a look at workplace adjustments depending on their age or if they are still working. So how can we keep them in work? Is there something we can do on modifying hours, activities, using your Med3 amended duties, not always not fit to work? And that, again, having that patient knows what they need to be aware of. So there's loads of patient information leaflets out there so that they know what is a change. Using that steroid card, so we've put them in the chat as well, giving that to the patient and almost telling them the significance of, if you know signs of GCA, that is not a do not pass go, head straight off. So that safety netting is a key part. And then that is all. So this is your time. If you've got any questions for any of us, please put it in the chat. So you'll get sent this out. Denise will send this out afterwards. It's got all the resources. You've got lots in the chat. That's a good point. So if you're a paramedic, you can use the Allied Health Professional Fitness to Work form. Physios, OTs, that's where you can use the Med3 alongside GPs. And then you'll get your references. So kind of what is the research saying? And just a reminder to using the Grow Knots app to look at all the different resources and all the different events that we've got on.